All right, everybody, so we can go ahead and get started. First, I just need to state it as part of the CME criteria. Please be aware, this is a CME accredited event. There are no commercial sponsors of this grand rounds, and the disclosures were reviewed and no conflicts of interest were found. So it is my pleasure today to introduce Dr. Mayra Sanchez. She earned her MD from the University of Miami. She also was an internal medicine resident there and then completed her gastroenterology fellowship here at Yale. She then joined the Division of Digestive Diseases here at Yale, and in 2011, she took over the directorship of the Yale Gastroenterology Motility Program, and she's been the director of the program since then. We're really fortunate here to have a group that specializes in functional GI disorders. It's something that we share a lot of common patients with them. In adults, I know we think a lot of it in times in children, but there are a lot of coexisting urologic and colorectal benign conditions in adults as well. So she is going to talk to us today about defecatory and anal disorders. Thank you.
Thank you for the invitation. It's a pleasure to be here today with you guys. I hope that the talk is not boring. I enjoy these topics, but I know that you see common patients, and we had some multidisciplinary meetings like Tori and Leslie know about it. So many information here is going to be repetitive for them, but I hope that it's going to be new for you guys. When talking about defecatory anal disorders, I want to focus in the things that we can do something about it, that we can be proactive, and to try to avoid the complications that you guys then faces, especially the urogynecologists, the urologists, and the colorectal surgeons. I wanted to start it with a little background. This is going to be repetitive for you, but pelvic floor disorders affect 10–15% of the population in general. And the more knowledge we got about anatomy, physiology, and rectum, the more will we understanding these disorders and do something about that. 23% of the women have at least one pelvic floor disorders, and you, the physician that specializes in gynecology, see a lot of that. The most common pelvic floor disorders are fecal incontinence, urinary incontinence, and pelvic floor prolapse, but then we have the defecatory disorders as well. And the defecatory disorders have a prevalence of 22 per 100,000 persons per year. So this simplifies the importance of understanding. This is a cross-sectional view of the anatomy of the anal rectum, and you understand this better than, because of your surgical background, than me. But you can see we had the rectum, and we had the anal sphincters, the pubis rectalis, the configuration in the rectum, the location associated with other organs, especially in the woman with the bladder and the uterus. It brings a lot of other issues in place when they are pelvic floor issues, because sometimes the manifestation of these disorders are mostly seen by the urologists or the urogynecologists when the patient comes with urinary incontinence. But as you actually question the patients, sometimes this is associated with fecal incontinence or defecatory problems. And I think that is where we overlap. And the better understanding that what are our limitations from my part and vice versa, the better we know and we can provide better care for the patients. I want to give you a little schematic view of what is the process of defecation, because that will help us understand how these things happen. So defecation is a voluntary process. There is the rectal distension triggers defecatory reflex. Then when there is favorable conditions, patient go to the restroom, the diaphragm, abdomen, and rectal muscles contracts, and the pubis rectalis and external anal sphincter relax, and then the patient had a bowel movement. When there are no favorable conditions, then when we are busy, we contract our pubis rectalis and external anal sphincters, and then bowel movement doesn't happen. But we need to get a good coordination and innervation and strengthening of those muscles for the process to happen smooth. So any alteration in these muscles, sometimes traumatic or for age or etc., can produce problems. And you know, like especially in constipation is very prevalent. I doubted that you guys don't deal with constipation. Probably one patient that complain about it in a daily or weekly basis. And we all know the patients that come and complain that they have been straining, hours pass, they don't have a little bowel movement. Sometimes it gets tiresome to hear that, but you know, imagine the patient that suffer from that. So, but the good thing is we had a better understanding of the constipation. I'm not gonna talk about the constipation that gets better when you change your diet, drink more water, get fiber, and those patients barely complain to us. They will tell, oh yeah, a little constipated, I just need to drink more water. And I'm gonna talk more about the constipation associated with pelvic floor dysfunction, but to give you a little background, there are three types of constipation. The normal transit constipation, that is the one that, you know, if you drink a lot of coffee, no exercise, your diet is poor in fiber, not drinking water, you can have an on and off. Just correcting your behavior, that will go away. Then you have the pelvic floor dysfunction, defecatory disorders. That is when there is an incoordination of those muscles that I explained to you about, and the process doesn't happen smoothly. And then you have the slow transit constipation when there is a problem with motility in the colon, and then the transit in the gut is so slow that patient ended up having constipation. This could go concomitant with a pelvic floor dysfunction, because if somebody wants to have a bowel movement, go to the toilet, strain, then you can see that sometimes the coordination of the defecatory process get altered as a compensatory mechanism, because they kind of forget what to do. And then in those two events, that's when we see a lot of the other conditions like rectocele, enterocele, prolapse, and that you deal with that. So pelvic floor disorder defecation that is gonna concentrate. There are structural problems that are more surgical concern, but that we see it often. We can see the rectal prolapse, the rectal mucosa intersuccession, the solitary rectal ulcer, rectocele, enterocele, descending perineal syndrome, and the functional problems that are dysenergetification. That is what I'm gonna talk about it. Most of these times, as I mentioned before, dysenergetification lead to this. And so when you found in your practice these findings, you should evaluate for this dysenergetification problem even before consideration of repair, because you should start the patient on treatment before, ideally. Sometimes the significance of the prolapse or the rectocele is such that you actually need to do it concomitantly, or maybe just do a repair first and then do it. But ideally, it's better to start the evaluation and treatment for the dysenergification problem as soon as you identify it. Most of the time, even when there is you guys know this, a small amount of prolapse, enterocele, or rectocele, just with biofeedback and therapy and changes in regimen, you can get some improvement on the patient conditions and prevent the progression of the other anatomic structural abnormalities. That, I think that is the most important concept to understand here. I wanted to review the ROM4 criteria. The ROM criteria were revised last year for the functional identification disorder. The patient must satisfy, and this was controversial because the previous version was like 10 years ago, and then they didn't consider IBS constipation a part of defecation disorder. And I'm happy that they included, because I really believe that IBS-C, or even IBS-D, is an umbrella term that unfortunately people use it rampantly. And I think everybody that had constipation diarrhea, they put it for IBS without doing the proper or the diligent evaluation. but the patient must satisfy diagnostic criteria for functional constipation and IBS-C, and plus had at least two of the following. Evidence of impaired evacuation based on balloon expulsion test. That's one, I'm gonna explain a little more about it, but when we do the evaluation with anorexia manometry, we do a balloon expulsion test in patients to see if they had any problem expelling like the balloon. It takes more than 1 minute, it's pathological. Less than that is within normal limits. Also, they include evidence of impaired evacuation in an imaging study, and that could be MRI or barium defecography, and an anorexia evacuation pattern assessed by manometry or the first EMG. We perform almost everything. We don't perform EMG in our lab, but we do MRI defecography, we do the balloon test, we do the anorexia manometry. So it will be easy for us to see this. You will find that sometimes you do a manometry, you get this abnormality, you do the balloon expulsion, and you get an abnormality, but the MRI defecography is normal in the when they spread the gel, or vice versa. So it's important to know that you only need two of these. And obviously the patient needs to have functional constipation, IBS-C. I think there is a mistake here, and I'm gonna be a little, sometimes patients that have dyssynergia, they complain of passive incontinence because they go to the bathroom, they had an incomplete evacuation, but at the same time, they happen to have a weak sphincter. They go and try to do anything, raise a chair or do some physical activity. They had a little bit of leakage, and then they complain of incontinence. But the main problem is the defecatory disorder, that they had a dyssynergic defecation. And then, so they don't take this in consideration, and they don't make I mean, we know about it, but the wrong criteria was very narrow in that aspect. And it's important to note that patients with defecatory disorder, dyssynergia type, can present with fecal incontinence and constipation, both. And the key there is to ask, do you think when you go to the bathroom you had a normal evacuation? They will tell you, no, I feel that it's incomplete. I could not complete my bowel movement. No, it's not. I assuming the urologists don't talk a lot about bowel movements, but these are key questions and important to. So more concentrated on dyssynergic defecation is an acquired and mentioning an ability to coordinate abdominal, rectoana, and pelvic floor muscles, characterized by paradoxical anal contraction, inadequate anal relaxation, and impaired push effort. The question is why this happens. Sometimes this happens associated with poor toiletry training when the kids are small. So for all you guys that are gonna have kids or grandkids, don't be too obsessed in toilet training that you traumatize your kids that they develop this. And sometimes we can see, I mean, I re-study for kids, and then you can see that they are looking for complex things. But even my nurse, when she does the study, she realized the mother is too overbearing and obsessive about it. And that is important because that is something very easy to prevent for our kids' health. The other thing is like patients that had bad experience being raped, like 20 or 30% of the population that complain of these disorders has some type of sexual trauma. Other stuff is like sometimes it's common after having kids, patients, I think that there is an adaptive, you know, everybody that had kids and patients that had dealt with, the doctors that had dealt with delivery realize there is a lot of changes in the pelvic area, inflammation and pain. And you don't treat that appropriately, you don't discuss that with patients. Sometimes, unfortunately, they start contracting the sphincter instead of relaxing, pushing too much or inadequate relaxation. And that can actually lead with time to defecatory disorders. Sometimes we cannot find when this happened. And it could be a combination, something neurological, some neuropathies, some disorders like MS can present like that. So is, obviously there has to be a reason, but sometimes it's difficult. Age can put abdominal strain because we age with changes, and then it could be multifactorial causes. But what are the diagnostic tests? And those are the most important. Dr. Rao believed just with a rectal exam you will be able to diagnose. And the key to looking that, and you guys do a lot of vaginal exams when you're looking for all the disorders, but in the rectal exam, the key is to ask the patient to squeeze. You want to see if the external sphincter is good. You ask the patient to burn down like they're having bowel movement. It's at that time your sphincter is you feel that they are pulling on you or squeezing on you. That is not a problem. That means that they could have a defecatory disorder right there. But it's very subjective and it's difficult. Not everybody has the same expertise, but a good trained gastroenterology or physician and digital rectal exam can persist on abnormalities. The obviously, I want to include colonoscopy because there are certain red flags that make you do a colonoscopy. But I will tell you, where you get upset is sometimes in the community, they just do colonoscopies. They don't find anything and they stop right there. And then they go on 2 years later and they repeat another colonoscopy. I mean, like they are gonna find something for the constipation. This is like, is there red flags? The new criteria is basically you don't need to do a colonoscopy if you perceive that it's a defecatory problem. It's not necessary, but for the most part, if you had a family history or you have some bleeding or you had the age and never had one, will perform one. If the patient doesn't respond to conservative treatment because the patient comes with constipation, I'm not gonna jump and start doing all of this. Usually by the time that they come to me, they say that they try everything over the counter. They say that they have seen 2 or 3 gastroenterologists. They have 2 or 3 colonoscopies. Nobody is paying attention to them. They think that they are crazy, blah, blah, blah. So at that time, I start the evaluation. Most of the time, and this has changed over the year, the last guidelines, the AGA guidelines, recommended to have a rectal manometry first. Because the key is, like I explained before, you can have a defecatory problem as a consequence, and that can give you a transit, a slow transit study. So first you evaluate for anorectal manometry to see if there is dyssynergia. Dyssynergia is when the sphincter doesn't relax, the sphincter contracts, and you also at that time do the balloon expulsion test, as I explained, more than 1 minute is pathological. There is a caveat here. If the patient has weak sphincter, the balloon expulsion test could be normal because the balloon will fall off. So you need to take that into consideration. And then you can consider doing colon tracing study. That is a study, we can do it with 2 things, smart pill, we give a capsule, and then we ask the patient, don't eat anything for 6 hours, and don't take any PPI before the test. The capsule measures pH, temperature, and pressure. And then it will tell you how long it takes for the capsule to leave the stomach, how long it takes to travel the small bowel, and how long it takes to travel the colon. Sometimes constipation is a manifestation of gastric emptying or gastroparesis or a slow transient delay. And then we target those areas. But sometimes you can see that they come 5 days later, they still haven't exposed the smart pill. And then you know there is a problem here. So they do a rectal varicose test. We don't do that here, but mostly it's not part of the ROM criteria. I'm not going to talk about it, but the defecography, MRI defecography, and the barium defecography, we are looking, we put the gel, we are looking about what happened. This is important when you're suspecting. Some of these patients say, oh, I have pelvic surgery, and this started after. And then they repair, but after that, I have been pushing and pushing. I have to use my fingers to empty myself out, and this has been for 2 years. You are suspecting that there is a structural abnormality concomitant with the problem, and you want to know is something that they repaired already, and it doesn't need another intervention, if there is something else that we can do about it. And that is when it comes, those patients that had the anorectal manometer that showed that, okay, there is a problem, but the balloon is normal. Because remember, you need to have 2 of the three things. So if this is abnormal, but this is normal, I need to have this abnormal to be able to make the diagnosis. That is a little tricky because, you know, we try to be conscientious about the amount of studies that we order, and in the future it's going to be even more difficult to order MRI defecography like that. And we have been doing some in studies to see when it's indicated and when it's not. And there are some previous studies that have shown when you suspected a structural problem and when they fail therapy, but you cannot start really therapy until you made the diagnosis. So, and here, unfortunately, we don't do barium defecography, we only do MRIs. So I got a schematic, the smart pill that I told, the little capsule that measures pH, temperature, and sensor, looks something like this, and you review. It's very easy. There is another study that is more primitive, that still we are using it. I think that it will be probably this year, the last time, because they are not, the manufacturer is not making the capsule. We give the patient a capsule with little small dogs, metal dogs, they swallow, they go to get an X-ray immediately after, then they get my protocol 3 days and then 5 days. Is they are like 23 liters of those metal dogs, very tiny. By the 5th day, there should be less than 6 in the column. If there are more than 6, you have a transit problem. Or you can have defecatory problems, all of them are in the red. It makes sense because they move. This is the schematic representation of the machine that we use for an rectal manometry, and I'm gonna show, and this is just the MRI defecography, you guys are familiar with that. So what are the possible findings in this synergia? I mentioned about the digital rectal exam, what you find. In the colonic transit study, it could be abnormal. That's why we start always with an rectal. That could be retention of more 6 markers on day 5 or colon transit time is greater than 59. I forgot to put the number here. And a rectal manometer, you get one of 40 synergy patterns, and I will specifically mention that later on. The balloon exposure, failure to expel balloon in 1 minute. The rectal baristat, you get hyper and hypersensitivity, but it's irrelevant to the ROM criteria. And the defecography, you get port activation, levator muscles, prolonged retention, and ability to spread the barium, icing or stripping way, mucosa intoxication, angle rectal seal, changes in degree of angulation of the rectal angle. You know, sometimes we are surprising that we do the MRI defecography, we don't see anything that could explain the symptoms, but sometimes we are surprising of the findings, and then we say, well, this is not something that could help, and then you know, they go with the colorectal or Leslie Toby, they work together and they will do some of those surgeries. And then I want to specify a little more about the anorexia. It's a very painless test, very easy. I mean, the patient is in the left lateral decubitus, they put a small catheter that had 10 electrodes, there are one in the inner canal, one inside intrarectum, and then you had a balloon at the end. And then basically you just get information. You ask the patient, you get information at rest. You want to know is the arrest information give you information about the internal sphincter. You ask the patient to squeeze, that give you information about the external sphincter. And also some patients can squeeze very hard, but they cannot sustain it because the muscle is weak, is unable to fatigue easily. That information we get it too. And then we also can get a special reflex, red-to-anal inhibitory reflex. For kicks is more important because acting on that reflex, that means there is a possibility that the kid had Hirschsprung disease. And that, you know, that becomes another type of evaluation for the constipation. Surprisingly, we had diagnosed some patients in early adulthood with Hirschsprung disease that has been misdiagnosed as a kid. And sometimes you can have accent of the reflex because of rectal surgery, spinal canal surgery, neuropathies, diabetes, etc. We also get information about the sensation thresholds. And it's important because some of the patients, they don't go to the bathroom because they don't feel anything. So in order for you to go to the bathroom, you need to feel that you need to go to the bathroom. And the thing with that is you then tell the patient, you wake up, you got your coffee, you sit in the toilet for 20 minutes, you don't push. Eventually, it will become norm for them to have the bowel movement, even without the sensation that they need to have it. It's important, I didn't put it here, the colon goes to sleep at night. As soon as you wake up, there is a spike in colon activity. And that spike increase also after eating with the anorectal, the gastrocolon reflex. So you take advantage of that. You tell the patient, wake up, and sometimes they want to have a coffee first. That will actually give an extra spike, go and sit on the toilet. And then I try to make sure that I tell that to the pediatric gastroenterologist that call me when they find some of these abnormalities. So the rectal sensation, as I say, and then we do the balloon expulsion test. This is what normally should happen. Forget about this. This is like the line tracing, and it's gonna be too difficult to explain. But here, these are the rectal sensors, and this is the anal sensors. This is the pressure at baseline. Patient is waiting with the catheter, the sphincter is closed, the pressure is high pressures in the red area. You ask the patient, like pretend that you're having bowel movement, relax. Like push down to relax the sphincter. The increase in intra-abdominal pressure should relax the sphincter. Should relax the sphincter more than 20% of the baseline pressure. If that doesn't happen, or if the patient contracts, sometimes they contract, then you have a defecatory partner. And there are four types. Nobody so far has demonstrated one type is different than the other. There are some speculation, but the treatment is the same. So what I mean is in the way that you need to approach them. They are the same. The difference is like sometimes type 1, you increase the pressure, but you also increase the sphincter tone, anal sphincter. Type 2, no intrarectal pressure, then you increase the sphincter tone. Type 3, you increase the pressure, intra-abdominal pressure, but there is no change. And type 4, nothing happened. It's like a person they understand. And this is usually what happens normally. So the idea is when we do the anorectal manometer, we are looking for one of these. And that is together with a fellow balloon expulsion, then we make the diagnosis of dyssynergia. If that is present, but the balloon expels normally, then you can suspect it. And I try to just say, well, we will need to get an MRI defecatory, and depending, it's my patient, I may more lenient not to get it. But so what is the therapy? We will do a standard constipation therapy, and I use everything. So you need to review the medication, make sure you avoid constipation medication. Increase dietary fiber and fluid intake. Regular exercise, time toilet training, I mentioned early in the morning. Laxatives. But then biofeedback therapy is what will help this patient. You try to restore the normal pattern of defecation and to enhance the rectal sensory perception. Because sometimes it's like for the gentlemen and the ladies that wear a watch, sometimes you feel funny when you don't have the watch, but you don't realize that you have it. So these patients they are used to have the stool in the rectum. So they don't realize they need to go to the bottom. So it requires, sometimes you need to say, that is the sensation that you need to look for. And that requires, like the therapists that do this, they have to be in tone or wanting to help. Not everybody's like that. So this is like an schematic representation how biofeedback therapy can restore normal defecation. We are still fighting with some insurance that said that it's like investigative treatment, which is very sad. But you can see how the patient was known. This is before biofeedback. The patient was contracting the sphincter, and as the biofeedback, the patient was able to relax and then had a bowel movement. There are controlled trials of biofeedback for energy defecation in adults. As you can see, the summary is like biofeedback is superior to placebo and diazepam and anything else. I don't know what the insurance continue to say. That is an experimental. This is what is a standard of care for these patients. But you might find that in those cases, sometimes I send the patient then to physical therapy. And some of the pelvic floor physical therapies are very good in providing that type of therapy that the patients need. That the only thing, because they are physical therapy, they call it something else. Other positive therapies, sacral stimulation. I don't have a lot of expertise about that for the constipation per se, but you guys, I know that some of you play some of the device. Staple nasal relaxation, not something that I would recommend. Botulinum toxin injection, that is when you really see a very tight sphincter. And like I know that Hulda had told me that she has some experience injecting, but it's not something that she would like to do on a regular basis. Um, and this is a good algorithm. I think that what to deal with these patients. You suspect the defecatory disorder, then you confirm it with an rectal manometer and balloon expulsion test, and you send the patient, okay, you have it. Biofeedback therapy and dietitian to make sure they improve the diet. If there is improvement, okay, you follow the patient. No improvement, you repeat the balloon expulsion test and it's normal, then you can do colony trans because there has to be something else. That means if you corrected the problem, they still had a problem, you have to investigate further. If that is slow, then the patient had a slow transit constipation, and then there are very few, actually there is only one drug approved for that, that is not FDA approved yet, the Resolor Procolapride. Some of my patients that had this, and the drug is so benign and it should be approved in the next year or two in the United States, that we get it from Canada for them. Is the colony transit is normal transit constipation. But you also need to evaluate that some of these patients might be having a wrong perception of what is normal bowel movements, because if they don't have a problem and they might have no constipation, that will be the normal bowel movement for them. So especially some people get fixated that they need to get to the bathroom one or twice a day. And then you say, well, going every other day is okay, every 2 days okay, and they will say no. And then they start using enemas and take laxative, and it's unnecessary. So there is no improvement, but then you do the balloon signal expulsion trains are normal, then you get an MRI defecography because, okay, there is a structural problem contributing to this. And then if there's persistent dyssynergia, send it back to biofeedback, try to find another therapies because something is failing there. If there is no, then you can know this synergy, but then you can maybe find some abnormalities like rectal seal, rectal prolapse, normal anal pelvic floor relaxation, something else that they can try. And then if everything is negative, then there is a psychological consult, but it's positive, then you can refer it to surgery or discuss it with surgery for the further evaluation. Some of these patients, the surgeons will be like eager to intervene. Some of those patients, we probably send them back to therapy for a little longer before deciding. So I want to jump and talk a little bit at the anal sphincter because one of the common things sometimes is like my patients come to me and say, well, I had incontinence, and the worst part, yes, I have been able to live with this because it's a little bit, but I'm getting now a lot of urinary infections. Then my urology told me just to try to talk to my gastroenterology. And then it's important that we understand this because there are things that we can do. So I wanna, this is the schematic representation. I want you guys to understand that we had internal sphincter, external sphincter. We had the vascular cautions that also produce some protection. All of this together maintain the continence at rest. But this is our friend, the puborectalis muscle. When it contracts, favor this angulation, then that's what prevents for you to have a surprise. These sometimes with surgery get damaged or with multiple pregnancies, and then this contribute to the problem. So the understanding of all these little things, the sphincters, the puborectalis, the vascular culture, anything that alters this environment can contribute to fecal incontinence. Let me tell you something. I had an example. I think that I remember this patient. He came to see me, a male patient. He said, don't send me to pelvic floor therapy. I'm tired of doing that. I have fecal incontinence. This has been happening for 10 years. I did everything imaginable because at the end I said, look, the only thing, let me review your medications. The only thing that he was taking for kidney stones was magnesium for the last 10 years. And then I said, you know, the only thing, try to study magnesium, see what happened. He got cured. So sometimes you had certain capacity to deal with the issues, but that could be altered by something else. You need to make sure that the patients are not lactose intolerant. They are not having other issues like microscopic colitis or other type of things that is contributing to diarrhea, and that can be contributing to the incontinence. And then you try to focus the patient in and try to see if this is multifactorial. Most of the time it is, and there are things that you can do. But then I think that you guys understand this better, the problem than most people. And then, but I wanted to give you what happened at rest and during defecation. Rest, you had the pulmonary rectalis contracts, and that angulation prevent like stool coming out. During defecation, you relax the pulmonary rectalis, and then in the right condition, relax the muscles, and then the stool comes out. What happened with fecal incontinence? And you know, everybody knows the concept is recurrent uncontrolled passage of fecal material for at least 1 month duration in an individual with developmental age for at least 4 years. I would say I left this concept, but I also, you need to, there is flatus incontinence. Sometimes the patients are very embarrassed that they will just don't have control of that. And that also could be considered part of the incontinence. And this is caused by unerected dysfunction and disordered bowel habits resulting from a variety of conditions, as I explained. But what are the etiologies? Anal sphincter weakness from age, injury from delivering the babies, no traumatic causes, neuropathies, anatomic disturbance. I mean, sometimes with patients with IBD that have fistula, patients with rectal prolapse, descending perineal syndrome, inflammatory conditions, Crohn's disease, you see radiation proctitis. I see in a lot of men that have prostate cancer had radiation, and they come and they don't complain so much of physics, they complain a little bit of leakage of phlegm, mucus. Central nervous system disease, dementia, stroke, brain tumors, MS, spinal cord lesions, and diarrhea, as I mentioned, IBS, post-cholesteatomy diarrhea. So you try to look what are the things that you can target. Sometimes you know, we should not focus only on this. Obviously, there is some problem here, but it's concomitant with something else that maybe we can target better. And then that's what I try is the patient taking a medication that they making them to go to the bathroom more. The patient is having some colitis. If there is anything that we can do, because this require fix of this requires sometimes surgery, but also a lot of commitment from the patient to go and do the therapies. Diagnostic studies, we get a digital rectal exam, I mean, weak sphincter. We can do colonoscopy looking for other conditions that could explain the fecal incontinence. We do an rectal manometry looking for, is the sphincter weak, the puborectal no totally relaxed, the external sphincter, there is no contraction in the external sphincter. We also do pudendal nerve motor latency. We do endovena ultrasound because sometimes you can see this break in the sphincters that could be more than 50%. That's when I would say, okay, it has to be a surgical fix. Most of the times, less than that, we just do a lot of biofeedback, and the surgeons don't want to intervene for that because it comes back. And we can do defecatory MRI and MRI defecatory. We got a study because this has been being studied in patients with fecal incontinence. We did it here, that we find out that there is a significant contribution of the information that we get with defecatory about anatomic abnormalities that change how we intervene with these patients. So the anorectal manometry, this is what you will find in a normal patient. This is a patient with fecal incontinence. Look at how the sphincter is weak and almost non-existent. Sometimes I don't see anything. So obviously the patient is gonna have incontinence. So this is when you ask the patient to squeeze, and this is what you're supposed to do to see. This is what you see, very weak squeeze. This is when the external sphincter is affected. This is when the internal sphincter is affected. And then what do we do? Once we evaluate everything and we think that there is a problem with the sphincter, what we do? So No invasive, we reduce intake of foods that cause or aggravate diarrhea. As you are lactose intolerant, we tell them, please, dairy-free diet. Urge suppression technique, we kind of try to train the patients on that. I sometimes use on my patients when they had a very little and they felt, I use, okay, Lamotil, Imodium can help you a little bit with that, and they are happy with that. And other makes the, like clonidine. Biofeedback physical therapy, we we send it for strengthening and fainting. And I try to tell the patients, don't expect to go into 3 sessions and then be cured. You don't go to the gym for 3 days and then you get muscles. You need to go for 6 months, and don't call me before that. Once they understand that for 6 months they go, they exercise, and they it's not you will get 10 phone calls after 3 sessions. Nothing get better than that. Minimum invasive things, we sometimes can inject Solesta in the area where radio frequency have been used also. I don't do that. When it's needed, where we send it to the colorectal, they do sphincteroplastic, and we had a good expertise here in secondary stimulation implants, and the patients do, they are happy with the results and they do well. But you know, you compare biofeedback versus pelvic floor exercise for fecal incontinence, as you can see, is almost, is good, but the biofeedback is better. Okay, so when I don't kind of provide it, the insurance don't cover, I send it to a physical therapist. What I try to do is combine both. I tell the patient, go to see a therapist and then come here once a month so you understand we do biofeedback. Then we do biofeedback 3 to 6 sessions, and they go to see the therapist in between, because they are more capable of seeing a weekly basis. And they are supposed to do exercise at home as well. Sometimes they get devices that they can just, electrical devices that they insert and they can do exercise, and some of them the insurance pay. But I leave that more to the physical therapists. Good pelvic physical therapists, they know what they are doing with that. Then I want to also review a schematic representation of what we do with these patients. So fecal incontinence, we do clinical evaluation, including digital rectal exam, 3 local and rectal problems. Is persistent physical incontinence, we do balloon expulsion test. If that is a normal, then it's evacuation disorder. Do you remember what I said, that the wrong criteria doesn't include the fact that some patients present with this scenario, with fecal incontinence? And then you do biofeedback therapy. Is the rectal sensation test is normal, then biofeedback therapy, because the patient needs to be able to sense that they need to go to the bathroom. If this consists in a rectal manometry show normal sphincter pressures, then I think that basically we need to go to, they didn't say here, but we need to go and evaluate something else, because I don't think it's the rectal. It could be like overflowed incontinence. A weak sphincter, then consider endoenal ultrasound, imaging, EMG, neurophysiology, and then consider sphincter debulking. No improvement, you consider sphincteroplasty. Then it's like, and then if you find out issues, then you treat that on the line disturbance. But if they fail, you kind of start investigating and do the rectal manometry and start investigating which category the patient falls. Then I had a summary slide that the 2 most common pelvic floor disorders seen by the gastroenterologists are dyspnea, defecation, and fecal incontinence. We do anorectal manometry, endorectal ultrasound, MRI, and barium defecatory are used to diagnose these disorders. The mainstream therapies are pelvic floor physical therapy and biofeedback, and the identification of proper treatment of these disorders help avoid complications seen by frequented by you guys, the gynecologists, the colorectal surgeons, like bladder, uterine prolapse, rectocele, enterocele, recurrent UTIs, etc. And I think that that's the most important learning thing, that identifying these disorders, proper referral to us with time can help in the long term avoid this type of complications and avoid surgeries in the long term. I don't know if you guys had any questions, anything that I can answer. Thank you.
Always the sphincter. I mean, because I do a lot of urinary. overactive bladder, more or less, or an sphincter that's not working well. And so we do urodynamics to assess the bladder, to determine if it's a bladder or a sphincter problem. It seems like when you do anal rectal manometry, it seems like you're focusing more on the sphincter.
Yes.
And it seems like if they have incontinence, it's pretty much always a sphincter problem.
No, I agree with you that we need to look at those because sometimes I had sphincters that are totally normal, but the patient had incontinence. So the problem is there. I cannot target the sphincter. I might recommend pelvic floor exercise, but then it could be that the patient had an like it has something else that is giving him diarrhea or her diarrhea to the point that the barriers that they had, is overflowing continence. They cannot compensate. That is not that common, but that happened, especially on patients that had, like, for instance, patients that had C. diff. You will see that they are very incontinent, or the patient had horrible gastroenteritis. They might have normal range in a sphincter strength, but what they have, that aggravation, they cannot compensate. So when that happens, I see that the sphincter is normal, I start looking for some other thing because it's not normal. But as you said, the way that we focus this is different because that you are able to assess how the bladder contracts. I'm not able to assess what is happening with we can do a transient study. That will be the equivalent saying, okay, if your transient study is like, so a patient with dumping syndrome, like they have bypass surgery and then all of a sudden they dump. Sometimes they had incontinence, sometimes, not all the times, because the diarrhea is overflow diarrhea.
One more question. So sacral modulation, you think that works for fecal incontinence because it does something to the sphincter? Because again, urinary incontinence, I think we think it does more something for the to the bladder. Yeah. So in your case, you think it's the sphincter, what it tightens it up?
I think it's the sphincter because the sphincter innervation, everything happened just at the level of the. But remember, I like to think about the sphincter. It's not only the sphincter. I think that you need to well all the anorrectal muscles. They do something with probably the pubis rectalis, the recto, the sphincter. No, I cannot say to you the colon will be the equivalent of the bladder, but I think the rectum will be the kind of the equivalent of the bladder. There is some type of, and I think that you guys are more advanced because you had two organs than us in understanding that, and it's a little more tricky. But I think that there is something else, especially patients that had a proctitis or sigmoiditis for IBD, sometimes they present with, they don't have involvement on the rectum in a canal, but they present and they have good sphincters with diarrhea or some leakage because of the activity that they're having above. And I think that when you put the sacral stimulation, you are targeting all these areas around it. But I really cannot quote you any data.
Thanks, Mayra. I have two questions, actually. One is what's going on with microbiome of the gut and motility disorders, because that seems to be a big deal for the urinary tract. And what do you think about the microbiome explaining everything that's wrong functionally? Which also ties into the second question, which is that mind visceral organ axis, of a guy named Mayra in UCLA, who believes all gut disorders actually have this central component, CNS component, which may interact actually with a microbiome as well. So is this all sort of just fluff that isn't really, because this is all very localized of what you're talking about right now, sphincter function, rectal function, but what about those other areas?
So I think that going to one extreme or the other, there's some truth in between. I cannot say that all GI issues are in the brain, but I cannot say that some of them are not in the brain. I would say that 30% or more of my patients have some comorbid mental disorder, anxiety, depression. You will see a lot of dysenergic patterns, and you can see those patients have an anxiety off the roof. It's difficult for me to say this is the beginning of the consequences because nobody wants to not being able to poop for a week. But we notice that. And I just don't think that you can say in absolute, everything start here. Eventually everything start here, but you're gonna say that. For the microbiota, It's not my area of expertise, but I will tell you this. For instance, patients with motility disorders, they complain a lot of bloating. And many of these, they don't qualify. They don't like, we investigate, they had a small bowel bacterial overgrowth. Some of them, the evaluation is negative, total. But you're taking care of the patient. You give them the treatment, they get better. They come back and say, oh, my bloating is gone. But if you follow the guidelines, they don't. And then there is something about the bacteria, this regulation. You can see a lot in patients that presented with weird GI symptomatology after they had an event that they have to take a lot of antibiotics. And they come back and they all of a sudden they had some colon dysfunction that I cannot explain because they don't have neurological problem. The event was never neurological. So I wonder if there is local dysregulation of the microbiota is contributing to that. And you know, the things that are more important, I will say, in GI about microbiota is that years ago, the beginning of this experiment showed they got mouse and they put the fat microbiota in a skinny mouse and the skinny microbiota and the mouse that was fat got skinny and the skinny got fat. So, you know, I wondered what could I do to lose weight? I said, maybe I need to use some of the microbiota. But I'm telling you, you have seen patients that you see, they don't have any endocrine disorder. They consume 3,000 or 4,000 calories that any other normal person will gain weight and they are like this. It has to be something explaining. So I think that little by little, we are gonna know more regarding the synergia and, you know, the anal disorders. I don't think that microbiota will have a lot of input, to tell you the truth. It's more structural and functional, how the coordination of the muscles. But regarding functional disorders, I think it will be very important. We are the beginning of understanding more. Right now, for instance, the last time that we had DDW, the big thing was we are testing androgen test, the androgen breeding test to see if you have lactose and lactulose. We have that capacity, but we are not testing for fructose. What they are noticing is like, people are telling you eat more fruit and more legumes and everything is high on fructose. They compare the consumption of fructose currently compared with what it was in 1920. It's just like 70% more. And they say, we don't have the capacity. One thing is to eat fruit. It means one thing is our portions are like this, that we consume this amount of fruit. Then they say you reduce the amount of fruit intake, you probably alter the microbiota in some way, the patients will feel better. And there are a lot of new, you know, I think that the way a format diet based on changing your diet, you can, they believe that then you can change microbiota too, which makes sense. And that's why the GI symptoms get better with that.
I don't know if this is working. Yep. One is that, to Harris's point, you know, having worked with Mayra for the last few years, that there is a lot of overlap between urinary and bowel evacuation disorders, but there's also some differences, because I used to try to think of the bowel like the bladder, and what I've come to well, I mean, we sort of know it, but what I've come to appreciate, I guess, is the bladder is sort of a closed system. You know, like there's the bladder, you know, like people say, oh, my kidneys, this or that, could that be causing my incontinence? Probably not, you know. But for the bowel, for the rectum to work correctly, you have the pelvic floor, you have the internal and external anal sphincter, but you also have the diaphragm and the abdominal wall and all of that has to work together too. So I think there's a lot, in my mind, more potential factors that could affect lower GI, we call it motility disorders, but elimination disorders, I guess. My other comment, and I don't know what you think about this, Mayra, when I think about possible ways that InterStim works for fecal incontinence, is like Dr. Sanchez says, sometimes people have a strong external anal sphincter, but it's a discoordination issue. And you know, the internal anal sphincter is autonomic control, and those two have to talk. And so there's, I think in some patients, a lack of coordination. So even though there's something in the vault, like it's not, the internal anal sphincter isn't telling the external anal sphincter to squeeze. So that person can squeeze, but if they're not getting the biofeedback and the sensory retraining so that they can communicate again, then you can do all the strength training you want. So there may be some autonomic internal anal sphincter changes that happen also. But I don't know. I don't know if you have any thoughts about that.
No, I think in those patients that had the normal sphincter pressures, I agree there has to be this coordination because you can relax your sphincter. And then if you have the strength to contract, then that means that you can be having that you can be continent. So I believe that there could be a discoordination, like she said. That's the only explanation. But at the same time, it's very difficult because what is happening in actual life is not the same what you're replicating in a lab. You know, when you are in a lab, the patient is focused in what you are asking to do. One of the things that happened that you had the seepage, when you had this inertia, is like you get up, you go and move and exercise. You are not thinking about contracting your sphincter. And the stool is there, and you relax the sphincter because the sphincter, external sphincter, get fatigued, and then you have to relax. And then going back to you, there are some patients that we laugh. You know, we had a joke about it. We call them tie ass because the patient will complain that, you know, they have the rectal pain, they are difficult to poop. Then you do on a rectal, you do a rectal exam, impossible. It's impossible. They break your finger. You cannot get in. And then you go like, I don't know, you know, and then you do an rectal manometry, and then it's just so tight that and then I think that is when some personality disorders or some abnormality neurological is contributing to the problem. So I really sometimes use, you know, antidepressant, trying to send it to psychiatry, buy all the type of, you know, biofeedback, but more to relax your body because if they don't have a scar tissue, they don't have inflammation, they don't have anything, why your sphincter can break a pencil, you know? It sounds funny, but you know, it's not funny when you're trying to deal with those patients. They tend to be very aggressive, type A personality. They are just complaining because they don't understand what to do about it. No, I tell you, anything that will work for my patient that will not be invasive. The first thing that I did, I bought a squatty potty, I put it in my office. So what and some patients, that, especially when they have some structural abnormalities, I tell them to use the squatty potty. And there are patients that will tell you the only way that I'm able to go will be to put my feet on the toilet. You know, I don't want people to do that. They can fall. You know, these people are not young. But then some of my other patients will tell me, you know what, Dr. Sanchez, I went to Italy. And when I go into Italy to the public bathroom, and when you go to Italy, you get surprised sometimes it's a hole and you need to squat. When I went there, I noticed that when I was doing that, I didn't have any problem. Obviously, saying then I tell them, get the squatty potty, it costs $20-something.